So in this next section, we'll talk about questions that are raised by a first seizure. The first thing I start off with is, was the event even a seizure? Remember, a seizure being the outward manifestations or what you see on the outside as a result of abnormal discharges in your brain. There's 5 cardinal manifestations or typical features for seizures that I talk about, and that'll run through my mind when a family is describing a spell to me. First of all, we know seizures tend to be brief, less than 3 minutes. There are prolonged seizures. There's even a condition where seizures go on could potentially for many hours called status epilepticus, but typically seizures are brief, less than 3 minutes. Seizures are usually recurrent, which doesn't help for the first seizure, but if there's recurrent spells, it makes it more likely to be a seizure. Seizures are paroxysmal. That means there's not a gradual buildup to it. It's a sudden onset of symptoms. So this is where if I have a family who says, commonly they'll say, my child's trying to do homework or we're disciplining them, they'll start crying, get fussy, and it builds into this meltdown, and then they're unresponsive, and I think they're having a seizure. That's less likely to be a seizure because seizures are usually paroxysmal. There's not a gradual buildup to them. They tend to be spontaneous, and that means there's no external cause. There's nothing obvious that brings on a seizure. There's a few sorts of seizure types where things can bring them on, like juvenile myoclonic epilepsy, which I talked about earlier, is one of the photosensitive epilepsies where flashing lights can bring on a seizure. But typically seizures are spontaneous, not brought on by anything. And then seizures are stereotyped. That means they're the same every time. And this is an interesting thing having to do with where the abnormal discharges come from in the brain. So if I have a family who comes in and they say, sometimes the right arm twitches, sometimes the left leg twitches, sometimes there's facial grimacing, that's less likely to be a seizure because the abnormal discharges in one part of the brain should produce the same seizure over and over. There is such a thing as multifocal epilepsy. You can have different seizure types, but that's much less common. This is a very important part of this presentation in general. Is the manifestations are typically characteristics of what to expect from a seizure. They tend to be brief, recurrent, paroxysmal, that means it comes without a buildup, spontaneous, not brought on by anything, and stereotyped, same every time, which has to do with the location of the abnormal discharges in the brain. Now there's other features when I'm talking to families that are more common in epileptic seizures. Eyes being open. This is something that was well studied, especially in the setting of pseudo-seizures or what we call non-epileptic seizures. With pseudo-seizures or behavioral events, spells which are not due to abnormal electrical activity in the brain, eyes are almost always forcefully closed. In real epileptic seizures due to abnormal electrical discharge in the brain, eyes are usually open, often with what's called aversive gaze or nystagmus, the eyes being jammed to one direction, maybe an upward gaze, or nystagmus, which is unusual eye movements during a seizure. Facial twitching is a pretty sensitive indicator for seizures. There aren't too many conditions that can cause facial twitching. There's hemifacial spasm and tics. The ways to differentiate these movement disorders or muscle spasms from seizures is that with a seizure, there's usually some brief behavior arrest or alteration in consciousness. A person having a tic will continue to go on about their business, their activity, and talking as if nothing happened. Where a seizure, there's behavior arrest. And same with hemifacial spasm. So facial twitching is a pretty strong indicator that the event was a seizure. Ictal incontinence or tongue biting, a person who wets their pants or has a bowel movement during a seizure or tongue biting is usually indicative of a seizure. The tongue biting usually on the side of the tongue as a person's having a seizure. The tongue may flop to the side and get bitten rather than, say, the tip of the tongue. And then the post-ictal state, the effects after a seizure. This is one way I help differentiate a little bit between, say, a syncopal episode or having syncope and seizures. What happens when the seizure is over? With a seizure, there's usually a post-ictal state after effect, having some sleepiness and confusion. Once we've determined that a spell actually is a seizure, the next thing is figuring out what type of seizure was it. Was it a focal seizure involving just one part of the brain, a generalized sort of seizure, And then is it a symptomatic seizure? Are we worried about something causing it? Or is it part of say, an epilepsy syndrome that we might see in children? We'll have to talk about what kind of studies need to be done. One of the important things is whether or not to do an EEG. The practice parameters from the American Academy of Neurology recommends an EEG after a single unprovoked seizure. A couple reasons for this. The first is it's the best predictor of seizure recurrence. So if you have a single unprovoked seizure and an abnormal EEG, the seizures are very likely to recur, somewhere near between 50 and 60% chance of recurrence. With a normal EEG, the 5-year recurrence rate for a single unprovoked seizure is about 1 in 4. Whether or not to start medications after a single seizure, again, is somewhat controversial, and you might get different opinions from different neurologists. A lot of it depends on the type of seizure, how long it was, whether the EEG was normal, and then if there's any other sort of symptoms that the child's having. What's the risks versus benefits of starting the medication? If the neurologist thinks that there's going to be more seizures because of the EEG, some sort of developmental problems or other underlying medical condition, be more likely to start a seizure medication. And a person without any epilepsy risk factors and a normal EEG would be less likely to think of starting a medication.